So today we'll be discussing about fatty change. Fatty change, otherwise the synonyms are steatosis, fatty degeneration, or fatty adipose degeneration, or otherwise known as fatty change. Usually it is a condition where there is excess accumulation of the lipids, where the lipids are being there's retention of the lipids within the organ system, and the most commonly organ where we find this lipid accumulation is the liver, which is the target organ. And this is mainly because when there's impaired synthesis or otherwise impaired elimination of the triglyceride fat or otherwise a kind of lipids, this causes the accumulation of lipids, resulting in a condition known as steatosis. So these lipids which have been accumulated, they usually are being stored in a vesicle, which is a membrane-bound organelle which appears oval in shape, and this is a structure where the lipids are being protected. And they are coming to the mainly microscopic features. They appear in two forms, that is the microvesicular steatosis or otherwise the macrovesicular steatosis. The term macrovesicular indicates that it is a large vesicle which is in a condition that the lipid is so much, the accumulated lipid is in such huge quantity that the nucleus which is present in the center of the cell is being displaced to the rim of the cell. So there is a condition, there is a histological terminology, macrovesicular steatosis. Coming to microvesicular steatosis, it is a condition when there's not enough lipid that displaces the nucleus, where the nucleus is in its position, is known as microvesicular steatosis. Usually steatosis in mild cases, there are no detrimental changes, that is, there are no harmful changes to the body. But whereas in severe cases, we see there is a burst of the cell because of increase in the accumulation of the lipid within the cell seems to burst and release these lipids into the circulating blood fluids. And the other type of accumulation, very huge accumulations or large accumulations, there will be disruption in the cellular constituents, that the cellular constituents, that is the organelles other than the lipid structures which are present within the cell, they get disrupted, they get disturbed. Thereby their functions also get hampered or altered. So coming to the risk factors, usually it is most commonly seen in diabetes mellitus because of uncontrolled sugar levels, and most commonly in diabetes type 2 diabetes, where it is since liver is an insulin resistance, it is more has a risk. It appears to be a more risk factor in diabetes mellitus. Coming to protein malnutrition, because of inadequate intake of protein, the lipids, the lipid content is being accumulated. So it is most commonly seen in conditions known as kwashiorkor, which is a malnutrition. There is sufficient calorie intake in that condition, but there is insufficient protein intake. So this results in protein malnutrition. So there is a condition which seems to be a risk factor for steatosis. Then the other conditions include hypertension and presence of cell toxins, which even disturb the lipid metabolism as well as the elimination of the lipid from the body, even is being considered as a risk factor. And other factors such as obesity, that is high calorie intake, which causes accumulation of lipids, and anoxia and even sleep apnea are the risk factors, considered to be the risk factors. Coming to the pathogens, usually it is not a single factor which affects results in steatosis, but there are even multitude of pathologies which together combine and result in steatosis. Coming to the macrovesicular steatosis, as already described, it is very huge amounts of lipid get accumulated. So there is oversupply of lipid in case of macrovesicular steatosis, whereas in case of microvesicular steatosis there is not such amount, but whereas there are intracytoplasmic inclusions of the lipid bodies, that is the lipid being enclosed within vacuoles where they are present within the cytoplasm. This is known as microvesicular steatosis. And for example, given an illustration in an alcohol addicts or alcohol drinkers, we see that once this alcohol is being intaken, that ethanol, which is a principal content of alcohol, it starts to break down. That is, there is a breakdown of this ethanol molecule. During this breakdown of ethanol molecule, along not only the other components are being released, but also energy in the form of nicotinamide adenine dinucleotide is being released. This NADH, which is being which is being terminated as NADH, this is a form of energy, chemical energy. So this energy usually functions in producing certain signals. These signals, they inhibit the breakdown of the fatty acids, that is, they stop the breakdown of the fatty acid. Fatty acid is a molecule which is supposed to be broken into smaller metabolites for for easy physiological functions to be normally functioning. So NADH produces that signals which usually cause the prevent the breakdown of fatty acid. Thereby there will be, so once this fatty acid is not being broken down further, not being metabolized, it accumulates in the body. So there will be increased in the fatty acid synthesis thereby in the body. This fatty acid synthesis acts as a false sense of energy. It's not a true energy which produces energy to the body, but it is a false energy, resulting in a condition where there is increased in the lipid than which is required. So the complications associated with steatosis are lipid metabolism failure. That is, the lipid which is now already present lipid is not being utilized, or there's failure in the utilization of the lipid which is already being present, or otherwise failure in the elimination of unnecessary lipid. This constitutes a lipid metabolism failure. Then otherwise there are even toxins such as alcohol, carbon tetrachloride, aspirin, diphtheria toxins, whereas other toxins which involve with the lipid metabolism, that is the removal from the body, is being hampered by these toxins, thereby resulting in increased accumulation of this lipid and resulting in a condition known as steatosis. So Gaucher's disease is a kind of condition which can be given an example for steatosis, where we see a condition of steatosis in this Gaucher's disease along with other associated abnormalities. That is, mainly Gaucher's disease is because of abnormal functioning of the lysosomes. Lysosomes are the cell organelles which constitute hydrolytic enzymes. These hydrolytic enzymes usually are involved in the digestion of the cellular contents. That is, when any harmful substances are present in the body, these lysosomes, they release the enzymes, that is the hydrolytic enzymes, and they cause the enzyme digestion of the harmful substances and thereby protect the body. But in Gaucher's disease, since the lysosomes fail to function to their maximum limit, this causes the accumulation of lipid, that is, so where unnecessary lipid is not being removed because there's loss of enzymes being released from the lysosomal cell organelles. Coming to another condition where we see steatosis is kwashiorkor. Kwashiorkor is a disease usually seen in children where it is a condition because of inadequate intake of proteins. Proteins are not being sufficiently taken by the body of a child. So when there's not being sufficient protein intaken, but there are sufficiently present calories in the body. So this calories are being utilized in the form of energy. So it's not they can be utilized in the form of energy only for limited period of time, but since protein intake is not at all sufficient in kwashiorkor, so these calories are only being utilized in the form of energy, which could be harmful, releasing the increased lipids and causing their accumulation and resulting in steatosis. So coming to the histopathological features, grossly, when you take an organ, when an organ, a fatty liver or any fatty accumulated structure is being taken, section from the body is being detached from the body, we see that the organ is being enlarged. Because of this organ enlargement, there will be lightening in the color. That is, whatever the color of the organ is, it becomes lightened. And macroscopic structure, that is when a thin section, when a section of this organ, which is being a gross specimen, is being taken, that we see that there's a lipid present within a membrane-bound liposome. That is liposome. If you split the word liposome, it means lipid containing body. Soma indicates body and lipo indicates lipid. So lipid is present within a body. This is what we see in a macroscopic feature. That is a thin section of a gross specimen of a fatty changes of any organs in the body. So these liposomes are present within the parenchymal cells. Coming to the microscopic feature, since lipid is a structure which is being water soluble, so this structure during when processing of this section of a macroscopic section of a affected organ, this lipid is being removed from the this microscopic structure. So because of that, they appear as empty spaces within the cell. So usually when we take use certain lipid retention molecules or liquids in the processing of histopathological processing, there are chances for this lipid to be present within the body. So there is a histopathological picture where we see a hematoxylin eosin stain histopathological picture where the white spaces, that is the empty spaces, indicate that the lipid was present but it is being lost during this histopathological grossing time. So, and the darkly blue stain are the structures, they are the nucleus. They are, we see each cell that they are being pushed to one side, being pushed towards the edge of the empty space. That means it is a macrovesicular steatosis. That is, lipid is being accumulated in such a level that the nucleus is being completely displaced from the center position. So this ends the fatty change. So coming to amyloidosis. Amyloidosis is a protein disposition disease. That is, the proteins which are non-soluble are being accumulated in an area, resulting in a condition known as amyloidosis. So when any insoluble protein is not being broken down into, which is not being further metabolized, these proteins, they break down into polypeptides, and this polypeptides result in a formation of fibrins. These fibrins are thread-like structures which together accumulate, resulting in formation of a fibrillar protein. So this fibrillar protein is usually non-soluble. So this non-soluble fibrillar protein usually accumulates in the body, resulting in the form of a condition known as amyloidosis. Amyloid is usually a protein which is a non-soluble fibrillar protein. So there are three types of amyloidosis which can be seen. That is a light chain amyloidosis, which means that the light chains which are immunoglobulin light chains, they could be either immunoglobulin are the molecules which are involved in the protein immune functioning of a body, where they act against any harmful substances or foreign antibodies which enter into our body. They fight with those substances and protect our body from harmful effects of those bacteria or any harmful external stimuli. So this immunoglobulin, if we take it as a single structure, it is a protein molecule which could be made of lambda or otherwise kappa body. So any single chain of this immunoglobulin is being affected in AL amyloidosis. It is called AL amyloidosis because it is a light chain amyloidosis. So it is a condition which is most commonly seen resulting in a macroglossia. That is, in dentistry, macroglossia is a condition where there is increase in the structure of the tongue because of abnormal deposition of this non-soluble fibrillar protein. Coming to autoimmune amyloidosis. Autoimmune amyloidosis is so-called denoted as A amyloidosis because A indicates autoimmune and A indicates amyloidosis. So it is also because of a non-soluble fibrillar protein which is a part of serum amyloid protein which gets deposited in the body and results in the formation of autoimmune amyloidosis. This autoimmune amyloidosis is a condition which can be seen in autoimmune conditions such as systemic lupus erythematosus is a condition where we see, otherwise, and even in rheumatic arthritis is also a condition which was autoimmune amyloidosis. So hereditary or familial amyloidosis is a condition which is being transmitted from parent to the offspring because of an alteration in the protein structure. Usually, most commonly, we see that this condition is being seen affecting the central nervous system or otherwise the eyes. So it is a rare condition which is least commonly seen when compared to the AL amyloidosis or autoimmune amyloidosis. So coming to the pathogens, usually a protein structure is usually formed by either a single piece, it is usually protein is formed made up of one single piece, or otherwise a sequence of amino acids is one pattern of formation of protein. Otherwise it could also be because of 2-3 patterns which combine together, that is a protein fragments, they join together and result in the formation of a completely formed protein structure. So usually we see in amyloidosis that there's flip-flopping of these proteins. So during the proteins being forming into a sequence, that is into a proper sequence or a sequence which is being exactly wanted, or otherwise the protein fragments, when they join together, they are being organized under a sequence which is being coded. So but in case of amyloidosis, we see that there is misfolding of this protein. They are not being properly arranged in a sequence, rather they are being misfolded, that is in an unorganized condition. So this misfolding causes a proteolysis, that is a breakdown of the proteins occur. This breakdown of the proteins results in a formation of undissolved misfolded proteins, that is the proteins cannot be further metabolized. This results in formation of aggregates. These aggregates of this non-soluble proteins are arranged in such a way that the water-soluble protein structures are towards the end of the protein aggregates, whereas the insoluble protein structures which are not soluble to the water, these proteins are present in the middle part. This causes the insolubility of this protein. So they are known as hydrophobic aggregates, that is which are not water soluble aggregates. This water soluble, which are not proteins which are not water soluble, are being stabilized by certain other structures known as glycosaminoglycosides and serum amyloid proteins. These proteins, they help in stabilizing these non-soluble fibrillar proteins, resulting in formation of oligomers. So the hydrophobic aggregates, with the help of these glycosaminoglycosides as well as serum amyloid proteins, together constitute to form oligomers. These oligomers help in the formation of amyloid fibrils. Thereby these amyloid fibrils together join together, accumulate together, and result in formation of non-soluble fibrillar protein, a condition known as amyloidosis. So coming to the signs and symptoms, usually they are broad and depends on the site of the accumulation of this amyloid. So based on the organ system, we can say which condition it's going to lead to. So when it is being the amyloidosis is seen in case of kidney, there's a nephrotic syndrome. That is, there's a improper or disturbed infiltration of the proteins, which results in failure of the kidney to properly function and resulting in nephrotic syndrome. When it is heart, there's even some abnormalities in the diastolic as well as systolic conditions, where it could result in heart failure because of abnormal deposition of this protein. It might form as a block, or which might block the blood flow and result in infarcts. And other condition could be liver, because of abnormal accumulation in the of these proteins in the liver. It could result in liver enlargement. Since liver is the organ where these are being metabolized, so it might result in the failure of the liver, ultimately resulting in liver enlargement because of its accumulation of excess overload in the liver. And the blood vessels, usually there is a rupture of this blood vessels, and there is a bleeding into the vicinity of these areas of the blood vessels, which results in raccoon eyes. That is the dark pigmentation around the eyes, which is known as raccoon eyes. Coming to the tongue, which is the most important feature in a dentistry, that is enlarged tongue can be seen. That is an abnormal increase in the size of the tongue is a condition because of the amyloidosis seen in dentistry. Diagnosis, usually the type of amyloid protein, it can be determined based on certain molecular techniques which have been recently introduced and most commonly being used in the advancing technology. That is, their detection can be done in the bloodstream. That is, proteins, since they are easily floatable structures, since they are the micromolecules, they can be easily circulating along with the blood, and so detection can be done with the help of extracting blood from the patient and thereby exposing them to certain serum electrolyte analysis, where the proteins presence can be detected. Coming to immunohistochemistry. Immunohistochemistry is a antigen-antibody complex, where an antibody which is antagonistic to these proteins, which act as an antigen in the body, are being exposed to these antibodies are being exposed to these antigen. They both of them combine, and on further process, these are being stained as the desired color, which can be viewed under the microscope. So this helps in detecting the presence of amyloidosis. Coming to electrophoresis, that is, the heavyweight protein molecules are being separated. That is, the negative charge of the proteins are being attracted to the positive charge. This is another technique known as electrophoresis, which can be helpful in detecting the type of amyloid protein. So this is a histopathological picture of an amyloid, showing the dark green apple birefringence is the structure which determines that there is presence of amyloid in this microscopic features. This ends the amyloidosis. Coming to hyaline chain. Hyaline, which is not actually a specific marker for any injury or any harmful substance, but rather it's a descriptive term in a histological section or a tissue. Since it can be viewed only under a microscope, it can also be told as a microscopic feature. So hyaline, it could be an alteration within a cell or within an extracellular space, can also be observed. So when we see under a stain structure, most common stain of a hematoxylin and eosin stain, hyaline change, it usually appears as a homogeneous pink eosinophilic area, with there will be uniformity in the entire area. That is, you don't find any disturbances, but it is uniformly pink, and which appears glassy, that is, which appears shiny in structure. This means that the tissue or the cell is undergoing hyalinization. So hyaline change or hyaline degeneration, it could occur in any form of condition. Most commonly we see in cases of injuries where the collagen gets hyalinized. So when the collagen gets hyalinized, it could be called collagen hyalinization. Coming to the intracellular hyaline deposits and the extracellular hyaline deposits, give an example of reabsorption droplets. That is in a kidney where there is infiltrates are being absorbed and they get transmitted through the further metabolizing process. But whereas in when there's hyaline changes, we usually find that there's water retention of these droplets and they are found accumulated within a vacuole. So this is what is reabsorption droplets. Coming to Russell's body, which are also the homogeneous structures which are present within the plasma. They could be immunoglobulins which are being produced by the plasma, which could give an appearance of a hyaline change. Otherwise, alcoholic hyaline or malice hyaline, which is also a structure which shows a glassy pink appearance, that is the hyaline change. Coming to the extracellular hyaline examples, or example of a collagen fibrous tissue can be given in a scar, where during the scar formation after an injury, usually we find that the collagen gets accumulated together and they are no more appearing as thin fibrils of collagen fibrillar structures, but rather they appear together, bundled together, resulting in a formation of collagen hyalinization. And otherwise, we can also see in long-standing hypertension as well as in diabetes mellitus, where the arterial walls, they show that there is a hyalinization of these arterial walls because of certain deposition. It could be a clot or any proteins. So this is a picture showing the hyaline changes, where an artery which is being denoted by an arrow mark, there's an hyalinization being shown within an arterial wall. Coming to gangrene. Gangrene is a decomposition or being a loss of a cell structure that because of a necrotic undergoing a structure. Gangrene denotes decomposition of the cell structure because of necrosis, or otherwise because of insufficient blood being supplied to that particular organ or a part of a body. So coming to the process which is resulting in gangrene is necrosis, usually because of insufficient blood supply, which is the critical to pathogenesis for the condition of gangrene. So gangrene, it is a potentially life-threatening structure. It may also result in death of a patient in case of gas gangrene, which is rapidly spreading because of the which is a gas which is being released by the bacteria, can result in a death of the patient within few hours or days. So this is a potentially life-threatening condition. Coming to the primary cause, as already told, it is because of a reduced blood supply to the affected tissues. Thereby, these structures are being stagnated with already flowing or pooling of the blood, resulting in death of that particular cells. There's increased risk in case of diabetes and long-term smokers, since these are more exposed to conditions where there is lack of blood being flown within those organs. They are being denoted as, they could constitute the risk factors, that is the diabetic patients as well as the smokers, long-term smokers. Coming to the types of gangrene, they are the dry gangrene. Coming to dry gangrene, it is usually a condition where gangrene is seen where the skin appears dry, so it is known as dry gangrene, and the skin even appears as shrunken structure with a proper demarcation between the normal structure of the leg as well as the affected part. Most commonly seen in the lower limbs, where we see that that too in diabetic patients, where we can say it's a diabetic foot. The picture is showing that there's a pigmentation of the leg because of stagnant blood flow, and it's a condition mostly because of the coagulative necrosis of an ischemic foot. And coagulative necrosis is a structure where the normal architecture of the necrotic tissue is being maintained, but whereas it appears changes in the color, that is there will be changes, that the degrading changes will take hours to days. So here we see that ischemic foot is being exposed to coagulative necrosis, which results in gangrene. So suppose this ischemic condition affecting the foot, if it has been recognized in the early stages or at least at the late stages of ischemia, that is where there is insufficient or inadequate blood flow, this could be reversed by a treatment known as revascularization. That is with a proper supportive blood flow to that particular area which is lacking, can be reversed into normal condition, normal foot, if it could have been recognized in an ischemic condition. But since the ischemia progresses to dry gangrene, that is lack of blood supply resulting in further degradation of the organ or a particular part of the body, this results in dry gangrene, where the foot, thereby the skin, overlying skin, it gets dried off, and it keeps being getting dispatched away from the structure. That is, auto amputation is a process which occurs where the skin is being loosened off upon its own self, and thereby it appears shrunken also. This is a condition we see in dry gangrene. Whereas in wet gangrene, it is a condition where they are thriving bacteria. That is, the bacteria, they flourish, they increase in growth in such a way that they produce their fluids. They excrete certain fluids, which is an infectious fluid. This infectious fluid communicates with the normal flowing fluid within the body. So both of them, they communicate to each other, they get mixed, and they get they rapidly flow into the body and spread the infection from one area to another area. So in wet gangrene, as the name itself suggests, since the presence of there is a fluid, it appears edematous, as well as there is even erythematous condition. So coming to gas gangrene, it is a condition where the bacteria, most commonly the Clostridium, they release exotoxins. These exotoxins are usually present in the soil or otherwise carried through any mosquitoes or bacteria. Once they enter into the body, these exotoxins, they act becomes as a toxic substances in the body, which are being transformed, they being interposed into the blood fluids or other circulating fluids, and then they result in produce gas, which is very toxic to the body. This gas, it constitutes of hydrogen, carbon dioxide, oxygen, as well as nitrogen. This gas is such a toxic such a toxic nature to our body that it can cause it when it spreads rapidly in the body, resulting as we can see in the picture, that there's gas which is being oozing out in the form of blood, which is being edematous, and this can even lead to a life-threatening position and result in death of a patient if not treated in a particular early stages. So this is a gangrene. Coming to healing. Healing, it is an ability of a damaged tissue of a life to restore into its normal function. So it's a normal ability of a human life to restore into its lost functions. That is, when on exposure to any injury, the body functioning system is designed in such a way that it can restore it to its normal function by a process known as healing. So in healing, usually lost structures are being replaced. It could be by repair, where there is replacement of the lost structures by formation of granulation tissue in the form of scar, and otherwise regeneration, that is replacement of almost all the lost structures as well as restoring to its normal function. Coming to the differences between regeneration and repair, we see that in regeneration, usually there is complete restitution, complete restoration of the damaged structure, whereas in repair, there is replacement of this damaged structure, but with the help of scar formation. A scar is formed with the help of deposition of granulation tissue. This granulation tissue is composed of collagen, fibroblasts, blood vessels, whereas other cells which are involved in the healing process, they together form the granulation tissue. So this is what the difference we see in regeneration and repair. Repair, we see that there is regeneration as well as formation of scar tissue. Whereas in regeneration, where we see that replacement of the lost structure with the cells and tissues, which can be with the help of their proliferation. That is, the existing cells and tissue, they proliferate and result in the formation of this lost structures. So usually when there is a complete loss of an organ, or otherwise an organ is partially being removed from the body, say about in kidney, when there is nephrectomy done, there are few chances for the kidney to be for the existing cell to multiply and restore it, but there are very few chances. So there is a very rare regeneration of the whole organs or a complex tissue. Whereas in repair, we see that the scar is a predominant structure, which we see when the extracellular matrix framework is severely damaged. That is, the framework or the extracellular matrix is being restored with the formation of scar. Coming to the classification of wounds based on the level of contamination. Coming to the contamination. Contamination, when organism or when any group of organisms, or otherwise when any debris is being entering into our body, that is which is infectious to our body, or which results in hampering our body functioning systems into a infectious condition, that is known as contamination. So This levels of contamination describe what type of wound is, whether it is an open wound. In open wound, usually we see that is it is a clean wound, that is there's no presence of any organisms, where the cut edges, that is the edges which have been displaced, that is when a skin is being torn or cut or lacerated, the edges are move away from each other, which results in a wound. So this wound, when we see in an open wound, that it is clean, which is does not have any contamination. But whereas in a closed wound, which is because of a blunt force or trauma, contusion, it it results in a deeper wound compared to the open wound. Open wound, it is a superficial wound, but whereas a closed wound, it is because of a deeper wound, or which is because of a blunt force. Whereas in infected wound, we see that there is microorganisms which get attached to these injured area, which results in an infectious condition. So which also, since it results in an infectious condition, we can see clinically the signs and symptoms of any infection, whichever respective organism is causing that condition of infected wound. And coming to a clean wound, which is a wound which is made intentionally in a medical field, when cases of incisions or excisions, when an infected part or infected structure is supposed to be sent for an examination to know what exactly the condition is, that is for a diagnosis of that condition, to know which disease is this. So we make intentional wounds, that is a part of that infected area is being sectioned under sterile conditions, and it is being sent for further pathological laboratory for further processing of the tissue to be viewed under a microscope, and further giving a diagnosis of that particular condition. So this is in a clean wound, this is what has happened, that is a wound is made under sterile conditions. Coming to a contaminated wound, when there are any accidental injuries which are associated with the presence of microorganisms which are being easily entering into a body, or because of the presence of foreign bodies, this results in a contaminated wound. That is a wound because of an accident or any trauma results in contamination, that is exposure of this wound provides an atmosphere or environmental condition that such that the bacteria come and lodge into the wound, that is contaminated wound. Coming to a colonized wound, similar to the contaminated wound, this wound, a wound which provides an atmosphere such that the organisms which have been contaminated into the wound, they grow, they multiply in number, and they get adapted to a body structure such that they result in more complicated conditions, which we see in gangrene. Coming to the process of wound healing, usually it can be divided into 4 phases. First phase, that is the first phase, initiation phase. Once there is any injury, immediately there is a bleeding, which is being controlled by formation of a blood clot with the help of coagulation factors, and the blood clot is formed, which prevents the further oozing of a blood, and this condition is known as hemostasis. And the second condition, that is the inflammation, which is a biological mechanism. It is a protective mechanism of our body, where the inflammatory cells, which are the neutrophils or the polymorphonuclear neutrophils, or otherwise the macrophages, they get involved, where they help in removing the unwanted foreign bodies or any debris which are usually harmful to our body, is being removed by a condition known as inflammation. So coming to next condition, once inflammation, that is once our body is being cleared with the debris and unwanted waste, the cells which are already present, these cells, they start growing by their multiplication occurs of the existing cells. That is already present cells, they result in a formation of increased condition, that is they grow into a increased condition by their multiplication. So this is known as tissue growth. Next, coming to the tissue remodeling, or otherwise tissue maturation phase. In this phase, usually we see that is the cells which have been multiplied, they mature, that is a progress, that is they grow in an extent that they show their maximum function in providing protective mechanisms to our body. So these are the 4 phases of wound healing. So hemostasis, coming to the detailed description of what happens in hemostasis. Usually when there is a cut wound, that there is bleeding. This bleeding, bleeding from these suture, from these cut edges, causes the attraction of the platelets to these injured sites. That is, the platelets come and they get aggregated to these injured sites with the help of some platelet adhesion factors which help in that is adhesion, that is they attract to the injured sites. Once these platelets go and they get attached to the injured sites, they get activated. These activated platelets, they result in the formation of clot. This clot is being formed because the platelets, they change in their position, such that the clot is being organized in a form according to the injured site. So these platelets, they modify in their shape. Once they modify in their shape, they it means that they provide a signal for the process of clotting to continue. So this clot is, once it is being formed, it releases a fibrin, which is a thin filamentous-like structure. This clot causes the activation of the fibrin. This fibrin bundles, that is the thin filamentous structures together. They form a kind of meshwork. This meshwork, it aids in creating an atmosphere such that the clot comes and it gets organized into this meshwork. That is, it gets forms as a plug within this meshwork, so that the clot is being prevented from its escape through the injured site. So once the clot forms as a plug within this fibrin network of blood vessels, it results in the formation of such a condition that there is no more further bleeding or oozing out of blood. That is, there is that creates an environment of prevention of bleeding. This what happens in hemostasis. Coming to inflammation. Inflammation, that is the damaged and the dead cells which are present along with the bacteria and other pathogens or debris which are harmful to our body are being removed off by a condition known as phagocytosis. Phagocytosis is a form of cell eating. That is, the phagocytes are the cells which engulf the debris or the unwanted waste or the bacteria they take up from our body and they ingest it, that is, they digest it, they eat it off, such that our body is being freed from these harmful substances. This is the process of inflammation, which is a biological protective mechanism to our body. Coming to the next phase, that is the tissue proliferation. It usually involves certain other stages. That is the first stage, known as angiogenesis. Angiogenesis is formation of new blood vessel from the already existing capillaries or the already existing blood vessels. That is, they divide and they give rise to new blood vessels. This is known as angiogenesis. Next, coming to collagen deposition. The fibroblasts, which are the cells of the extracellular matrix which are present in the connective tissue, they give rise to collagen. That is, they produce collagen. This collagen gets deposited in the extracellular matrix and forms a collagen fibers. This is known as collagen deposition phase. Coming to the granulation tissue phase, the cells which are involved in healing, they could be fibroblasts or the blood vessels or the collagen tissue or the further other cells which are even involved in the removal of the debris, that is a neutrophil. They together form the granulation tissue by their deposition around the clot. This forms a granulation tissue formation phase. Coming to epithelialization phase, that is the epithelium, which is nothing but the cells which are present in the skin. These cells, they divide. That is, the parent cells which are present above the basement membrane, they divide and give rise to daughter cells. This condition is known as epithelialization, formation of epithelium. Then coming to wound contraction phase. This phase is usually not seen in all the wounds, but it is most commonly seen in large wounds. When the wound is large enough in size, it decreases in size by a contraction. This contraction is brought by a specialized form of cells known as myofibroblasts. Myofibroblasts are nothing but they are the fibroblast cells which appear like fibroblast cells, but also have the function of fibroblasts as well as those of the skeletal muscle cells, smooth muscle cells, which have a contractile function. That is, they contract in size. This contractile function brings the contraction in the wound. That is, it decreases the size of the wound, which thereby results in a formation of a smaller wound, which progresses into the other phases of the wound healing. This is what happens in tissue proliferation. Coming to wound maturation, that is the structures which have been formed during epithelialization, granulation tissue formation, angiogenesis and collagen deposition. They all together mature. That is, they progress in their form, shape as well as in their function to a maximum limit, such that they function as a normal functioning system cells. But whereas in collagen tissue, we see that these collagen fibers, they realign themselves in conditions where there is too much of stress which has to be resisted by your body functioning system. Since collagen absorbs the tensile stress, these are the collagen fibers, they arrange along the tension lines. And thereby, in wound maturation, we also see another phase known as apoptosis. That is, unwanted cells, or the cells which have already functioned and they have completely exhausted, they can no more function, are being removed by a form of cell death known as apoptosis, which is a programmed cell death. And this is what happens in wound maturation. So once there is any injury to our body, the blood first phase is bleeding. That is, the blood oozes out. So along with this blood, there are even other cells which are being constituted within the blood are the red blood cells, as well as the platelets and the polymorphonuclear neutrophils and macrophages. So they all get attracted to the injured site. So once the blood starts oozing out, along with this, even certain red blood cells, they also ooze out within the blood. And the other stage which we see is the platelets are being attracted to the injured sites. These platelets, once they get aggregated to the injured sites, there is coagulation. That is, these platelets release a signal known as clotting. Release a signal which causes the coagulation, formation of clot formation. This clot, it forms, activates the fibrin. This fibrin, they form a meshwork, where we can see in the second stage that the fibrin which is being formed as a meshwork, and it prevents the escape of clot, where the clot gets unplugged. It gets blocked within this fibrin meshwork. So this is what we see in coagulation phase. That is the second phase. Coming to the next phase, inflammation. Inflammation can be divided into early inflammation and late inflammation. In the early inflammation cells, that is the first line of cells, that is the polymorphonuclear neutrophils. These are the cells which first reach the site of inflammation. Once they reach the site of inflammation, we see that these neutrophils, since they have only a lifespan of 2 days, they start showing their function in removing of the debris and the bacteria and the unwanted waste by releasing certain factors known as transforming growth factor beta and platelet derived growth factor. These factors help in removing of the cellular debris and bacteria away from the injured sites. And then once these polymorphonuclear neutrophils finish their function, that is, since they have only a lifespan of 2 days, they die after 2 days. Then the third day, and that is by the third day or the second to third day, the macrophages appear to arise in the wound site. They reach the wound site, which is termed as a late inflammation stage. The macrophage, the major function of the macrophage is to clear off, that is, cleanse the wounded area completely and debride it from the already extended, that is, the leftover debris which is being left over and not cleaned by the neutrophils is being cleaned by these macrophages. And even the neutrophils which have to be removed from the wound site, which have purposed their function, they are being also removed by these macrophages. This is what happens in the late inflammation or the second day of injury. Coming to the third day of injury, that is the proliferation phase, where we see that there's increase in number of cells, that is the fibroblasts, collagen tissue, along with it certain macrophages and also blood vessels, they start increasing, that proliferate, as we have seen in angiogenesis, collagen deposition, epithelialization. This is what happens in the proliferation stage. Coming to remodeling stage, that we see that the epithelialization has been completed. The epithelium, that is the injured site, is being completely covered up by a new layer of epithelium. Along with it, the properly aligned collagen along the tension lines and the fibroblasts can be seen, which usually takes a time period of weeks to months. This completes the wound healing phase. Coming to the wound strength. The wound strength, usually injured wound, when it is being sutured, when that is approximated, the edges are being sutured, they are being brought together with the help of sutures. There is 70% of the strength of a normal skin. That is normal this sutured wound site attains a strength of 70% of the normal skin. But once these sutures are being removed, that is usually a time period after suturing after 1 week, these sutures are being removed. Once these sutures are being removed, there is only 10% of strength being present of the normal wounded site. So this 10% of strength rapidly progresses within few weeks, that is, say about 4 weeks, the strength reaches to the maximum level. Then coming to the wound strength, which reaches to the maximum level, is 70 to 80% of an unwounded site. It reaches by 3 months of time period, it reaches to a normal wounded function. So this is what happens in a wound. Coming to nature of the wound. Based on the nature of the wound, healing could be of two types. Healing by primary intention or healing by secondary intention. Primary healing intention, where the healing occurs without any scar formation, since the healing occurs in a small wounds, small injured sites. But whereas healing by secondary intention occurs when there is a large wound, it results in formation of increased, since the wound size is large, there will be increased in the granulation tissue formation. Ultimately, increased scar tissue formation can also be seen. Coming to healing by first intervention, most commonly seen in clean surgical wounds, that is, wounds which are being made intentionally in cases of incision and excision, and even in cases of biopsies. It could be a brush biopsy or punch biopsy, where these injured sites or the surgical sites are being approximated, the edges are being approximated with the help of sutures. This is what we say in healing by primary intention. So a small scar is formed, not in which is indistinct from that of the large scar in healing by secondary intention. Coming to healing by secondary intention, usually we see that there's extensive, since the wound is large, there's extensive cell loss or the tissue loss, which results, which can be seen in abscess formation or ulcer formation. So during this phase, there is intense inflammation. The wound is large, there will be increased in the inflammation. That is, the inflammatory cells are too many, that the inflammation becomes intense. That is, increased inflammatory reaction. Ultimately, there will be increase in the formation of granulation tissue. This results in this granulation tissue. Once it is formed, there is wound contraction, which is being brought about by myofibroblasts. As already explained, these fibroblasts, these structures, there are cell structures, specialized myofibroblasts, that help in decreasing the size of the wound. That is, they bring about wound contraction, which results in extracellular matrix accumulation. That is, the cells which are being constituted in the extracellular matrix, that is the fibroblasts, collagen fibers, blood vessels, other macrophages and neutrophils, they get accumulated, and once they get accumulated, they result in the formation of a scar. Since it is a large wound, it results in a large scar formation. This is what happens in healing by secondary intention. So there is a picture representation showing the differences between the healing by primary intention and healing by secondary intention. The primary intention, we see that first there is a fibrin thread-like structure which is being formed from the epithelium to the connective tissue, that is from the dermis, which also involves the extracellular matrix. And coming to this in the second phase, that is, the wound edges are being joined with the help of this fibrin plug. Coming to the second phase, that is regrowth of the epithelium. Epithelium starts regrowing. It starts helps the restoration of the injured wound site. Thereby, there is epithelium being formed around the plug from the downwards. This is what we see in the second phase. Coming to the third phase, that is, there's complete lysis of this fibrin structure, because this is being replaced by the epithelium as well as the granulation tissue, and the fibrin decreases in size. Ultimately, this results in restoration of the intact structure, intact skin. This is what happens in healing by primary intention. Coming to healing by secondary intention, where we see that the wound size is large, being denoted by pinkish structure, that is fibrin, which is being restoring the wound lost tissue structure, which covers the epidermis as well as the underlying connective tissue. Then coming to the formation of granulation tissue. This granulation tissue, which consists of new blood vessels as well as fibroblasts, and this granulation tissue, it starts growing from downwards, that is from the connective tissue towards the epithelium, by replacing the fibrin structure. That is what we see in the third phase. That is, this granulation tissue also helps in production of scar, which replaces the fibrin structure and completely restores the epithelium, as well as which is restores the connective tissue to its normal function by formation of a scar tissue. This is what happens in healing by secondary intention. Coming to the differences between the secondary healing of secondary intention as well as healing by primary intention. As told, since the wound is large, there is large clot formation, and since there's large clot formation, there's intense inflammation reaction. That is, the increase in inflammatory cells, inflammatory atmosphere, which results in formation of large amounts of granulation tissue. This forms increased scar tissue, which also is the most important distinguishing feature between the primary and the secondary healing is the wound contraction, which we do not see in the wound healing by primary intention, because there is a small scar, small injury. But whereas in large scars, it requires decrease in the scar. Since there's a requirement of decrease in the size of the wound, there's wound contraction, which can be seen in secondary healing. This is what ends the differences between secondary healing and primary healing. Coming to the most important technique being followed in dentistry is extraction, which is very important to be known, since not only removing the tooth is important, but even knowing the process after tooth removal is being importantly to understand, because any differences in the wound healing, that is any improper wound healing, can result in a very difficult or critical situation known as dry socket. When there is any loss of the clot from the extraction socket sites, it results in dry socket, which is a very painful and uneventful wound healing condition. So it is important to know what happens during healing of an extracted wound site. So initially, once this extraction is being done, the extraction site is being filled up with the coagulation. This coagulation which happens, that is a formation of clot happens, where the RBC are being entrapped within this clot formation, and this clot it activates the platelets. These platelets release a chemical signal which form the fibrin. This fibrin together they join together and form a fibrin meshwork, where the clot is being enplugged within this meshwork. This is all what happens in a normal wound healing, but only difference starts from here. Then there is vasodilation. Vasodilation is a condition where the blood vessels, they enlarge in size. Once there is enlargement of this blood vessels, there is engorgement of this blood vessel. That is, there is increased fluid being entering into this blood vessel. Once there is increased fluid being entering into the blood vessel, there is mobilization of the leukocytes. That is, the leukocytes, they move immediately to the area around the clot. That is, they promote a signal which helps in movement of the leukocytes from the already existing site to the site of the clot formation. So they reach the clot formation and they form a thick layer of leukocytes which covers this blood clot. Similarly, a thick fibrin layer even covers the blood clot, since a clot is being enmeshed within this fibrin layer. So the clot itself next shows an area of contraction. So that is, the wound contraction can be seen here. So that is what happens immediately following extraction. But during the mean duration of first week of wound healing in an extraction site, we see the fibroblasts, all three existing fibroblasts that is present within the periodontal ligament remnants. These fibroblasts, they proliferate in size, that is, they increase in number such that they start growing into the clot. They ingest into the clot and they start growing into the clot. This clot, along with the fibroblasts, it acts as a scaffold. That is, it attracts the cells which are involved in the process of healing, and these cells which are attracted into the healing clot, the fibroblasts, they start growing into the clot, and this clot, it acts as a scaffold, and this scaffold means it starts attracting the cells which are involved in the healing. These cells, since they are involved in the healing, they produce a granulation tissue. This granulation tissue ultimately results in the formation of epithelium at the peripheral wound edges, where the epithelium, already existing epithelial cells, they divide by process of mitotic division and they form new epithelium. That is, re-epithelialization is a process which can be seen after the formation of granulation tissue. This is what happens in first week. Along with that, simultaneously, that is what happens in the superficial region, that is the epithelium and the clot formation. But whereas in the internal structures, that is the bone related structures, we see that the edges of the bone of the neck of the socket, also known as alveolar bone crest, since the bone edges are sharp, that is, they are severed, and they are even necrotic bone edges, that is, the bone edges which has to be removed. They are being removed by a process known as Osteoclastic Resorption process. Our body system, usually, it is being balanced by two functioning systems of the bone. One is bone deposition and the second one is bone resorption. So these are the functions. Bone is being deposited, that is, bone is newly being formed with the help of certain bone forming cells known as osteoblasts. Simultaneously, the bone, unwanted bone, is being resorpted. That is, there's even resorption of the bone simultaneously with the bone formation. That is, unwanted bone is being removed with the help of another bone resorptive cells known as osteoclasts. These are the cells which help in removal of the unwanted bone. So this is what happens in alveolar bone crest, which is being severed during the extraction site. That is, which is being damaged. That is, which is being unwanted and frayed structures. They are being removed with the process known as osteoclastic bone resorption activity. This is what happens. Along with that, internally to it, since the endothelial area, that is a vasculature area, there is a division of even this vasculature. The already present endothelial cells which are present in the perial remnants, they start dividing, they start giving rise to new capillary network. This capillary network also starts ingrowing into the blood clot, such that they get merged into the already present blood clot, and they coincide even with its functioning system. So once there is blood clot is being regrown with this capillaries, there is a new leukocyte layer, it forms around the clot surface, and simultaneously the wound edges, they are being continued, they move together with the help of re-epithelialization. This is what happens in the first week of wound healing of an extraction socket. Coming to the second week of wound healing socket, the blood clot, it start organizing itself more with the more ingrowth of the fibroblasts, as well as of the with the new delicate capillaries which are the present from, which are arising from the perial remnants. And ultimately, as there are new structures being formed, the perial remnants which are already present, they are removed by degeneration, they are being removed by unwanted the unwanted perial cells are being removed. Then along with that, there's even the bony socket wall, the socket wall which are being frayed, they are being removed with the osteoclastic activity, and there's even epithelial proliferation, that is a increase in the number of the epithelial cells. There's extensive growth of the epithelial proliferation which occurs at the wound socket, along with that of the alveolar bone crest resorption activity which can be seen in the second week of wound healing. Coming to the third week of wound healing, we see that the clot, it is completely organized with the help of new blood capillaries that provide new nourishment to it, and this clot along with the new capillaries and the fibrin meshwork and the fibroblasts, it results in the formation of new granulation tissue, maturing granulation tissue. Along with that, there is since as already explained that along with the bone resorption activity, simultaneously there is even bone deposition, that is newly formed bone, that is an immature or undecalcified bone, is even being formed around the periphery of the socket wall. Here what is we see, and the cortical bone, that is a bone which we see in two layers, that is the corticular bone as well as the trabecular bone the inner part, corticular bone the external part. That there is we see already formed cortical bone, it starts remodeling, that is they mature, that is they become calcified in structure. This is what we see in the third week of wound healing. And the alveolar bone crest which is undergoing bone resorption activity, it gets rounded off because the unwanted and hard and sharp edges are being removed by resorption activity. These alveolar crest, that is the neck of the socket, it gets rounded off. By this time, the wound surface is being completely epithelialized, that is the epithelium completely is being restored to normal function. This is what happens in third week. Coming to the fourth week, that is there is in the fourth week the major functions, that is the continuing bone deposition as well as bone deposition resorption occurs. Since the bone resorption is more, because along with the removal of the necrotic bone area, along with the normal physiological function, there is more of resorption activity compared to the bone deposition of activity. This is what the reason there is only minor changes in the alveolar socket, that is it does not reach to that of the adjacent normal tooth structures areas. And radiographically, there's a bone formation can be seen only during 6th or 8th week after the extraction. This is what happens in 4th week. Coming to the diagrammatic representation, what happens in tooth extraction. First, we see that the hemorrhage, red color area indicating the hemorrhagic area is being formed. Along with that, underneath the porous form that which constitutes the bone part. Coming to 48 to 78 hours after extraction, we see that the blood clot starts decreasing in size, which because of the formation of granulation tissue with the help of fibrin, platelets and fibroblasts as well as the collagen tissue. Because of this, the clot starts decreasing size, and there's more of deposition of granulation tissue. This is what continues next after the fourth day of the extraction, that the blood clot being completely reduced in size and being replaced completely by the granulation tissue. Coming to the 7th day, that is 1 week after extraction, we see there's a reduction in the granulation tissue because of some wound contraction, and along with that we even see primary osteoid formation, that is new bone formation can be seen. Along with that, we even see that new epithelium which is being proliferated, which is being indicated by pink in color. And the next 48 to 72 hours after extraction, this is what we see. that in the progressing weeks we see that the new connective tissue, along with that the osteoid's bone, it starts mineralizing, that is there's maturation, and the new epithelium is being completely restored such that it closes the wound site. And coming to the 6th week after injury, we see that it is completely restored to a normal structure with normally appearing epithelium, that is along with presence of oven bone, connective tissue, and the trabecular and re-epithelialization. This is what completes the wound healing. Coming to the process of thrombosis. Thrombosis is a normal structure, normal condition where there is hampering in the process of blood flow because of the formation of thrombus. Thrombus is nothing but a blood flow which is causing the obstruction of the blood flow. This process is known as thrombosis. So when this thrombus, that is a blood clot, is being dislodged from the from its site, normally formed site, to a which is being moved to other structures with the help of along the blood flow, it results in the formation of embolus. So this is what is the picture says that the left side being shown a normal blood supply, there's a normal circulation of the blood fluid, whereas in thrombosis, because of the formation of blood clots, there's a blockage, there's a disturb in the blood flow system, which results in thrombosis. This is what happens, and there is formation of oxygen. This results in since blood is not only the blood flow does not only carry blood, but also it's responsible for protection of oxygen as well as nutrients to other body organ system. There is even deprivation in the presence of oxygen as well as nutrients because of the process of thrombosis. Usually a small thrombosis that does not cause any problem, but when there is significantly large thrombus, there's hypoxia, that is decrease in the oxygen supply to the other tissues. And when there is extremely large thrombus, it results in formation of anoxia and infarction, that is completely loss of the blood to the area. Coming to anoxia, causes of thrombosis, we see that there's a triad. There are three major functions which have been recognized, which hamper the process of blood flow, that which involve in the causation of thrombosis. They have been known as Virchow's triad. They include hypercoagulability, or otherwise known as thrombophilia. It is a condition where there is increase in the formation of coagulation. There is increase in the formation of platelets, which result in the increased formation of blood clots that form this condition of thrombosis. Other than that, there is even endothelial cell injury. When there is a increase in the endothelial cell injury, there is this endothelial cell injury to restore into its normal function. There are being blood clots which are being formed, which this also causes it hampers the blood flow through these blood vessels and results in the formation of thrombosis. Coming to the other four, that is a disturbed blood flow. This is because any hampering, that is when there are any structures, obstructions in the blood flow, or otherwise the blood flow itself depends on since it depends on the thickness of the blood and even proper flowing of the blood pressure. When there is any proper disturbance in the thickness of the blood, or otherwise any blood pressure, it will also result in disturbed blood flow, which is also one of the causing complications in thrombosis. Coming to the pathogenesis, the hemostatic process being activated in an uninjured or slightly injured vessel results in the formation of thrombus. That is, normally during injuries only we see that there is a clot formation, but in thrombosis we see that even an uninjured vessel even results in a formation of a blood clot, which results in a process known as thrombosis. When there is a large blood vessel showing this condition, it is known as a mural thrombosis, but whereas when there is a small blood vessel, it is known as occlusive thrombosis. Coming to the classification of thrombosis, it is broadly classified into venous thrombosis and arterial thrombosis. When the thrombosis is occurring in the veins, it is known as venous thrombosis. When it is involving the artery, it is known as arterial thrombosis. Coming to the venous thrombosis, there are other conditions which we see in venous thrombosis, that is the deep vein thrombosis. This deep vein thrombosis is usually seen in conditions involving the lower limbs, that is in cases of majorly in diabetic conditions, or otherwise in strokes we see this deep vein thrombosis. That is a large vein which is present deeper in the deeper structures. It shows a blockage of the blood flow because of a formation of thrombus or a clot in the structures, where it manifests as a dark dark pigmented structures, and it can even result in the condition known as gangrene. Coming to portal vein thrombosis, which is a condition which is seen in hepatic conditions, where which involves a portal vein. When the thrombus involves a portal vein, it results in portal vein thrombosis. Coming to the renal vein thrombosis, that is in the kidney. We see when there's any hampering system in the infiltrating, which is a major function of the kidney, that is the products are not being properly infiltrated, or they form a thrombus which block the flowing of the blood from this renal vein. It results in a process known as renal vein thrombosis. Coming to the jugular vein thrombosis, we see that the jugular vein, which is usually a deep vein which carries the pulmonary functions, by this occurrence of jugular vein thrombosis, there are conditions which can be seen such as papilloma or pulmonary embolism. Coming to the other deep vein thrombosis which affects our cerebral venous sinus thrombosis, that is the cerebral venous sinus, where we see this structure is being blocked because of the formation of blood clot. And the other condition is cavernous sinus thrombosis. This the thrombus which is being formed in the cavernous sinus results in this condition. This is what explains the venous thrombosis, types of venous thrombosis. Coming to the arterial thrombosis, usually since artery, it carries the blood to the brain, so where stroke is a condition which can be seen, that is there's an improper functioning of the brain which results in the stroke of the brain, that is improper brain functioning. Even in myocardial infarction is a condition which we can see because of arterial thrombosis, since there's failure of this blood flow in the myocardium because of the blockade which is being formed by the thrombus. This results in myocardial infarction, which is in heart stroke, or otherwise known as heart attack. Coming to the other sides, which we see the arterial thrombosis, which includes the hepatic artery. So when it is includes the hepatic artery, it is known as hepatic artery thrombosis. Coming to the complications, embolization, that is formation of embolus in a particular area, localization of an embolus in a particular area. Embolus is nothing but a dislodged thrombus. Thrombus being moved from its actual site along with the circulating blood flow to a site other than the site of its origin. This embolization. This is what the complication. Coming to embolism. Embolism is nothing but it is formation of an embolus. Embolus is it is an occluding agent, which could be because it could be an occlusion either because of the molecules, metabolites, or otherwise a clot, or otherwise any metabolic byproducts which results in blocking the flow of the interstitial fluids or the blood flow, or otherwise the normal physiological mechanical functions which usually have a function of flowing in our body. So this process, embolism, it results in vascular occlusion. Here we can see that the large vein which is being obstructed because of an embolus, that is the blood flow is being obstructed. It is indistinct from the thrombus. Thrombus which is being only particular to its size, whereas embolus, it can even damage its sites of, or other than the sites of origin can be also be damaged in case of embolism. This is what happens in embolism. Coming to the classification of embolism, when it involves an artery, it is known as arterial embolism. When it involves a venous, it is known as venous embolism. When it is paradoxically embolism, that is from venous to arterial, usually it's seen in septal defects, that is in the cardiac system, where we see the septum that which separates the veins from the arteries. When there is any defect in this septum, it causes a movement of this embolus from venous to arterial and results in paradoxical crossed embolism. Coming to the direction, it is also based on the direction of the blood flow. When there is a normal flow of the blood, which is known as anterograde blood flow, this embolia is carried normally. But whereas when there is a so this embolism can also have a harmful effect even in the direction of the blood flow. Usually in anterograde blood flow, usually we see there is normal flow of the blood. But whereas in retrograde blood flow, because of the increased structure of the emboli, or otherwise because of the changes in the blood pressure, that there is opposite direction of the blood flow. This is what we see the complications because of the embolus formation. So this ends the topic of embolism. Coming to shock. Shock. Shock, coming to the shock, it is a term which describes that there is insufficient blood fluid being supplied to the body. It is a life-threatening condition which can worsen if not rapidly being treated. So typically it shows few signs which can be explained that the patient is in shock. When there is a low blood pressure to the patient, decrease in the blood pressure, which could be a possible cause why there is not proper blood flow to all the organs. And when there is even rapid heart rate, which also hampers the blood flow or the circulating blood flow to other body structures, could also be one of the signs why shock appears. And there's even signs of poor end perfusion, which means there's loss of urine output, there's confusion and loss of consciousness. This is what happens in shock, and these could also give a sign when a patient is in shock and readily be treated immediately, since it's a life-threatening and progressive or worsening disorder. So coming to the main causes why shock occurs is any condition which usually reduces blood flow would lead to shock. It could be either a heart problem. So when there's a heart failure or heart attack, since heart is the major organ which pumps the blood to all the body structures, when there is any problem with the heart, this could result in the formation of, this could result in a condition of shock. Otherwise, when there is any low blood volume, that is when decrease in the blood volume, that is, it could be because of the blood viscosity or the cell contents which are present in the blood, the increase in size, or which there could be any blood related problems, or the volume of the blood could result in shock. Coming into the changes in the blood vessels, these blood vessels, when they are affected because of any inflammatory reasons such as vasculitis or any other condition, when they are not being properly maintained, or when there is any defect in the septum, that is between the ventricles or any cardiac structures, this could also result in shock. And coming to the certain medications which have side effects on other structures which could indirectly affect the heart may cause shock, not directly but. So often there is heavy bleeding. Usually shock is seen in conditions where there is severe trauma or injuries which results in increased loss of blood, and this could come to a condition of shock. Coming to the pathogenesis, it mainly involves 4 stages. Coming to the initial stage, that is the first stage where it is a shock. Shock, since it is not only related to the blood, but since blood carries oxygen and other nutrients to the body which are very importantly supplied only through this blood, these conditions may lead to the initial stages of shock. So since there's lack of oxygen, which is a major content and the most important part which is supposed to be supplied to each and every organ, and because of this shock, the blood is not being properly being carried, and thereby decrease in the oxygen content can result in a condition known as hypoxia, where there is decrease in the oxygen content. So this is the initial phase of shock, where this in initial phase, since there decrease in the oxygen contents, the body has certain adaptive responses. During injury, as we see that there are certain adaptive responses where the tissue tries to compensate by increasing in size. Similarly, when there is no oxygen in our body, certain other structures or organs, they try to produce oxygen. So in the compensatory phase, where we see that there's rather than increased oxygen supply, there's increased demand for the oxygen. That is, the organ particularly wants it's in craving for the oxygen. So the body tries to give certain oxygen, but this might produce a negative effect by giving oxygen in a different way or energy in a different way, where this negative effect can progress and lead to a condition where the body cannot recover to its normal stage. This is refractory stage. This is in brief about the stages. Coming to the detailed description, what happens in the 4 stages is what this. Inadequate perfusion, that is inadequate blood supply to the body organelles, results in hypoxia, that is decreased oxygen content in the cell. This decreased oxygen content results in energy deficit. Since oxygen is a major component for any aerobic mechanisms that produces energy, which could be in the form of ATP or NADH. So since oxygen is reduced, there is also a decrease in the production of energy. So there is deficient energy atmosphere condition in the body in cases of shock. This decrease in energy Since there is a hampering of the Krebs cycle as well as the citric acid cycle, there will be accumulation of the lactic acid. This lactic acid starts fermenting, that is, it starts accumulating, and this accumulation results in fall in the pH. pH is a balance of the body functioning system, that is, the hydrogen ion concentration is being balanced. This is known as pH. So the body pH is normally at an alkaline level, that it maintains a normal basic balance, which is 7. When the pH is below 7, it results in acidic pH. When the pH is above 7, it results in basic pH. So since there is lactic acid base being accumulated, since it is an acid, it creates a condition that decreases the pH, that is, it creates an acidic condition. This acidic condition results in metabolic acidosis. Not only metabolic acidosis, but also this lactic acid accumulation creates an anaerobic metabolism, that is a compensatory mechanism which tries to produce energy in the absence of oxygen, which is more dangerous than lack of oxygen. So this metabolic acidosis, which is being created by the accumulation of lactic acid, it not only causes a vasoconstriction, but it also causes this acidic environment causes the damage of the certain structures such as cell membrane, which is a covering of the cell organelles. So along with the damage of the, because of this damage, there is production of failure in the sodium pump. Since cell membrane is a semi-permeable membrane in certain organelles, that is, it allows only permeability, that is, passage of only certain structures. So it helps in maintaining the sodium pump. So there is failure of this sodium pump because of this acidic condition in the body. Other than that, metabolic acidosis simultaneously also causes the failure, derangement of the blood vessels, that is, it causes vasoconstriction. It decreases the size of the blood vessel. When there is decrease in the size of the blood vessels, there is failure of the precapillary sphincters. These sphincters which help in the maintenance of the blood vessel by allowing the proper flow of the blood vessels, there is failure of this maintenance because the structures such as precapillary sphincters are being affected. Once these precapillary sphincters are being affected, there is no more flowing of the blood, there is no more circulation of the blood, rather there is pooling of the blood. That is, the blood remains stagnant in one condition. It remains only in one condition, that is, it pools up, provides a stagnant condition. It does not circulate into any other form. So this is what happens because of metabolic acidosis. So along with the vasoconstriction, as we have seen, that there is failure in the sodium pump. Because of this sodium pump, there is only presence of too much of sodium and water inside the body, and there is lack of potassium, that is, the potassium since the potassium, say failure in the sodium pump, the potassium is outside and the sodium and water being produced into the body, by which there is also harmful substances which are being released into the body, that is, a lysosomal enzymes. Hydrolytic enzymes in normal condition, they are usually cause the enzymatic digestion of the unwanted waste or the debris or the foreign bodies which are being harmful to our body, supposed to be removed from the body. But these these lysosomes, they are being ruptured because of the metabolic acidic condition which releases this enzyme. So these unwanted enzymes, they causes the digestion of certain substances of already existing proteins or otherwise other metabolic products. These digestion results in releasing of the polypeptides or the metabolic byproducts which are more harmful to our body. So these toxic substances which are being released because of the enzymatic digestion of the lysosomes, they enter the circulation and they mingle with the circulating substances, and they cause the damage of the capillary endothelium. Capillary endothelium is nothing but the structure which is covering the blood vessels. This is being damaged. By this, there is further destruction and disinfection, and progressively there is death of the cell. This is what happens in shock, which ultimately results in loss of blood being properly being reached to the destined organs. So coming to the types of shock, so we see when depending on the conditions or the organs which are facing this shock, they are being classified as types of types of shock. There is a cardiogenic shock when heart is being experiencing this condition such as shock. It can cause an heart failure or heart attack, or ultimately it can even result in death. This is what happens in cardiogenic shock. In hypovolemic shock, that is hypovolemia, that is there is decrease in the blood volume content in the shock. Hypovolemia means decrease in the blood content. This condition of shock could probably be in conditions such as burns, where there is loss, too much of fluid loss, otherwise in vomiting condition, or otherwise in severe injuries where there is huge blood loss. This condition leads to hypovolemic shock. The other conditions could be under hypovolemic shock. It could be an anaphylactic shock. Anaphylactic shock is anaphylaxis, that is which is a allergic condition which affects the entire body because of certain allergens, that is which are allergic to our body, or otherwise because of certain medication, which result in anaphylactic shock, where it can manifest as redness or otherwise itching kind of sensation to the body. These are the manifestations or clinical signs of symptoms of anaphylactic shock. Coming to septic shock, it is because of certain microorganisms or otherwise any toxic substances, which could also be because of certain medications which are being toxic to our body. This results in sepsis, which results in septic shock. Coming to neurogenic shock, when a brain which is being exposed to certain conditions like of lack of improper functioning or improper balance being maintained because of the derangement in the body fluids or the metabolites or any protein derangement, this could result in neurogenic shock. So these are the types of shock. So this ends the topic of shock. Coming to ischemia. Ischemia is insufficient blood being produced to the body. That is, there is restriction in the blood supply to the body. So blood, as it does not only carry blood but it also carries oxygen, there is even insufficiency in the oxygen being transported, and there is reduced oxygen availability of the nutrients also, because blood carries even the nutrients. There is even reduced availability of the nutrients to the body. So ultimately, because of the since oxygen and nutrients are also involved in the removal of the certain metabolites which are unnecessary to our body, there is inadequate removal of the metabolites in our body. So this is what ischemia is, and this is what the features which can be seen in an ischemia. Coming to the causes of ischemia, why ischemia occurs is because of the vasoconstriction. When there is decrease in the size of the blood vessel, that is the blood vessel contracts in size, so there is improper blood flow, that is the blood cannot flow as it does normally, that the blood pressure cannot be maintained, by which there is decrease in the blood flow. This could be one of the causes. A thrombosis, formation of blood clot even in injured blood vessels. So when usually a clot is formed when there is injury, but in thrombosis is a condition where there is no injury but the blood clot is formed because of unknown reasons. So because of thrombosis also ischemia can occur. Embolism can also cause ischemia, that is any fat metabolite or otherwise any metabolic substances or byproducts in unwanted ways which accumulate together and form an embolus and block the blood flow and result in condition known as ischemia, is one of the cause of ischemia. Coming to the ischemic acid, that is reactions which result in ischemia. That is initially when there is any metabolic waste products which are being increased in our body, that they build up in such a condition that they cause inability in maintaining the cell membranes. That is a cell membrane which is being maintained because of the fluids or otherwise the proper transport of metabolic substances is being hampered because of unnecessary waste being accumulated in our body. So by this unwanted waste being accumulated and resulting in compromised maintenance of the cell membrane results in damage of certain organelles, say such as mitochondria. So when the mitochondria is being damaged because of this unwanted metabolic waste, it releases certain autolyzing proteolytic enzymes that may be harmful to our own body functioning system, which cause the damage of certain substances, that is say proteins which releases polypeptides, and these are released into the cells and into the surrounding tissues which damage the entire body functioning systems. So this is what happens in ischemia. Coming to reperfusion, that is when ischemic tissue is trying to restore back to its function because of a normal blood flow. There are certain there are certain changes which happen. That is blood flow which is a condition is being reached where there is lack of blood flow to opposite, completely increased in the amount of blood flow. This is a condition of reperfusion, that is resupply of blood. This is a condition which happens. This condition could result in production of free radicals or reactive oxygen species, which are the metabolic byproducts of the oxygen derived or any oxygen structures, oxygen containing molecules which are being broken down, and they are the metabolic byproducts which are released, that is the free radicals or otherwise reactive oxygen species. These are the structures which are being formed. Otherwise they are even calcium overloading because of increased blood supply. Since oxygen even carries calcium, there's increase in the calcium level which results in calcium overloading, and there's exaggerated inflammation because of unnecessary body's functioning systems which results in overloading of calcium. It may result in inflammation which is being exaggerated. So these are the conditions which we see in reperfusion, that is restoration of the ischemic tissue. Coming to the signs of symptoms, easy way to remember signs and symptoms of an ischemic tissue is 6 P's. That is, there are six conditions which can be seen, which start with which are being initiated with the letter P. Firstly, we see pain. Because of insufficient blood supply, there's pain. Suppose you hold your finger and tightly hold your finger with a thread or something, you start seeing that there's change in the color of the fingertip because there is accumulation of the blood flow and there is loss of blood flow from throughout the finger, which results in painful structure, as well as there is even change in the color, that it appears pale, and there is even loss of pulsations. You don't find any pulse being seen, as well as paresthesia. Since there is loss of sensation, there is tingling sensation or prickling sensation which can be seen, and paralysis, that is completely particular structure or that organ, it does not function in any way, and poikilothermia, that is inability to maintain the temperature of the body. These are the 6 P's which are the signs and symptoms seen in ischemia. Coming to infarction, infarction is the condition where we see that the structure, there is deprivation of the oxygen. Since because there's loss of blood supply, there's also deprived oxygen being present, and the organ which is being facing this condition is known as infarct. So coming to the causes which cause the infarction is embolism. Embolism or thrombus, they are the structures which block the blood flow, which results in decrease in the amount of blood flow and ultimately result in decreased oxygen supply. Another condition known as atherosclerotic plaque, which is a damage in the arterial wall, where there is certain accumulation because of the damage of the arterial wall, result in hampering the fluid blood flow through these arterial walls. Similarly, atherosclerosis is also a structure where there is a sclerosis of the arterial wall. Coming to vasculitides, vasculitides is nothing but vasculitis. Vasculitides is a plural form of vasculitis. Vasculitis is a condition that is a inflammatory condition of the blood vessels. That is, since blood vessels are the major structures which help in blood flow, when there is inflammation of the blood vessels because of any damage to the blood vessels, it results in infarction. And vasoconstriction, that is the decrease in the size of blood vessels, can also result in hampered blood flow, ultimately which there is a decrease in the blood supply to the organ. Coming to the classification based on the localization of the infarction. So when the infarction involves the cardiac muscles, that is myocardium, it can cause myocardial infarction, which can cause heart failure, and cerebral infarction, loss in the function of the cerebral system because of the presence of infarct in the cerebrum, brain. That is spleen. When it involves a spleen, it is known as splenic infarction. When it involves a limb, it is known as limb infarction, formation of blood clots in the limb, or otherwise any infarct. Infarcts including the bone or the eye are even the types of infarcts which can be seen in the entire body. Coming to hyperemia. Hyperemia is a condition where there is increase in the blood flow. Hyper means increase, emia means blood flow. So it is a condition where there is increase in the blood flow. Usually it is a kind of regulatory response, that is when there is a lack of blood, blood supply which is being overcome by compensatory blood process, compensatory biological mechanisms in a body, results in regulatory response known as hyperemia. Clinically, since there is sudden increase in the blood flow, it appears reddish in color and manifests as erythema. Usually there is fall in the atmospheric pressure outside the body. That the blood flow is being maintained by proper hydrostatic pressure or a colloidal pressure in the body functioning system. So because of rapid sudden rise in this blood flow, there will be fall in the atmospheric pressure in the body. Coming to functional, metabolic or active hyperemia, why the hyperemia occurs? The process behind the hyperemia to occur is because the lack of certain conditions such as lack of blood supply or inadequate oxygen supply make certain cells become active. That is because as a process of compensation, since our body has an adaptive mechanism where it adapts to certain conditions where the cell tries to cope up with the damage which is occurring. So there are certain cells which get active and they start functioning into such as to restore the organ to a normal level, normal metabolic function, physiological function. So this is what happens. Once the cells get active, they release certain, these active cells, since they are so active that they release oxygen than the required amount. They release increased oxygen or the increased fluid content. Since this oxygen is a major metabolic agent which is required in the production of glucose or otherwise any kind of fatty acids, since there's overproduction of this oxygen, there's also overproduction of energy. And there's this overproduction of energy which is a major product which is required for the catalyzing the reactions in the metabolic process. So the overproduction of energy also exaggerates the action of the metabolic processes. That is, the metabolic process function in a more rapid way, or increased metabolic products are being produced. So as metabolic processes are also increased, similarly there are certain byproducts, that is the metabolites, which are unnecessary, are being even released along with these metabolic processes. These byproducts, they act as vasodilators. Among them, certain vasodilators are carbon dioxide, hydrogen and potassium. These structures, they act as vasodilators, that is, they increase the size of the blood vessel, by which there is dilation of the local arteries, that is the arterioles dilate. That means since there's large space for the blood to flow, then there's increased blood which is flowing through these dilated arterioles, and ultimately there's increase in the blood flow. This is what happens in hyperemia. Coming to the venous reactive or otherwise venous hyperemia. What happens in reactive or venous hyperemia is take a condition known as ischemia, that is where there is shortage of the oxygen. That is, ischemia is condition because there is lack of oxygen, because lack of blood supply. So when there is shortage of the oxygen, there is buildup of the metabolic waste. Since oxygen is also required to removing of these driving the metabolic waste out of a body, this results in increased accumulation of these metabolic waste, by which there is increase in the organ blood flow. Since oxygen increases, since there is increase in metabolic waste, there is ultimately increase in the organ blood flow for this metabolic waste to be removed of the body. This is what happens in reactive or venous hyperemia. So this is what explains the hyperemia. Coming to the adaptive responses. Since our body is made up of cells, and these cells are as normal structures which are confined to the function and structure by maintaining a normal function with the adjacent cells, otherwise with the state, they even maintain the state of the entire organ, and even they maintain the constraints of the neighboring cells, as well as they maintain the availability of the metabolic substrates. So basic functional unit of our body is cell, which helps in maintaining all these functions of our body. Coming to the adaptive responses, that is when a cell is being exposed to any injury, so our body has certain response in a way that it adapts to these injuries and helps to cope up on its own self by when there's any, say suppose there is any organ which is being removed out of our body, such as a nephrectomy, the organ tries to cope up, that is, it tries to restore its part which has been removed from the body. It might not restore it to a completely normal structure, but it might slightly at least replace the lost structure which has been removed. So by this, hyperplasia is a condition where these structures, there's a division of the cell. Already existing cells, they divide in number such that they increase in the number of cells. This increase in the number of cells is known as hyperplasia. When there's increase in the number of cells, there's increase in the size of the organ, since organ is made up of cells and tissues. So there's ultimately increase in hypertrophy, which is increase in the size of the organ. And atrophy. Atrophy is a structure when the unwanted cells are being removed, completely loss of the structure. And metaplasia is an adaptive response, that is, there's a change of a structure from one position to change in a type of a cell from one cell type to another cell type, where we see there's change in columnar epithelium to squamous epithelium in certain allergic conditions. That is known as metaplasia. This is adaptive response. Coming to edema. Edema, it is a accumulation of the interstitial fluid within our body. This fluid, it can be accumulated beneath the skin or otherwise beneath the organs. So it is clinically manifest as a swelling, because since fluid is being accumulated, there's increase in the size beneath the skin. This is known as swelling. So other terminologies which can be given for edema is hydropsy or dropsy. So this balance between in the amount of interstitial fluid is being maintained because of the balance of the fluid hemostasis as well as the increased secretion or unwanted removal or impaired removal in the unwanted substances. This maintains the interstitial fluid. Coming to pathogenesis, which usually affect this edema formation, there are 6 factors. Hydrostatic pressure, it is a pressure which usually maintains the flow of the blood or the fluids which are being passed in our body. That is, it maintains the pressure. So usually we see in edema, when there is increased hydrostatic pressure, there is increased in the amount of fluid accumulation. Along with that, when there is decrease in the colloidal or osmotic pressure within the blood vessels. Colloidal or osmotic pressure, they are the pressure which maintains the protein contents or the fluids which is present intracellularly and extracellularly. That is the movement of the fluids from the low to a higher solute concentrate. That is, there is decrease in this colloidal or oncotic pressure within the blood, thereby by which there is loss of movement of the fluid, by which the fluid starts accumulating only in one position. Or otherwise, when there is increase in the tissue colloidal or oncotic pressure, that is, as there is decrease in the blood pressure, as there is a decrease in the as there is decrease in the oncotic pressure within the blood vessels and there is increase in the tissue oncotic pressure, that is, this will cause factors which can cooperate with the accumulation of the fluid from moving outside to inside into the body. Similarly, when there is increase in the blood vessel wall permeability, that is, this permeability, once it is increased, there is lack of any movement of the fluids outside or within the body, by which also there is accumulation of fluid. So these are the major factors. Along with them, there are the other factors are obstruction of the fluid within the lymphatic system. Since lymph which is being produced from the lymphatic system is not being transported to the organs which requires this lymph, and there is obstruction of this flow of the lymph, results in also an edema. And the other ones are changes in the water retaining properties of the tissues themselves. Suppose there is increased uptake in the water, that is increased or overtaking of the water because of during conditions like hypoxia or ischemia, this results in also an edema. So coming to the classification of edema, the picture shows presence of indentation in one of the leg when the pressure is being kept. So we can see the indentation is being occurring because of the pressure applied by the finger. This is known as cutaneous pitting edema. That there is formation of pits in the edema. Peripheral pitting edema, when this involves peripheral structures such as the limbs, lower limbs, or any of the peripheral parts of the body. Non-pitting edema. In spite of applying pressure, there is no pitting seen in the edema. This is known as non-pitting edema. Generalized edema we see because of any side effects to certain medications or any hampering of the body conditioning or the circulating systems in our body, where the generalized body becomes hampered. It can also be seen in case of kidney failure, when there is loss of output from the kidney, where there is fluid accumulation within the body. This results in generalized edema. And organ specific edema, that is a specific organ only shows edema in the body. We can see in cases of swellings because of any traumas, where there is accumulation of fluid because of inflammation or pus discharge. This is organ specific edema. This completes edema.